All right, everyone. Good morning again. Thank you so much for joining us today. It is my distinct honor to present to you Dr. Jennifer Christie. So we have a special grand rounds today as we celebrate March as Colorectal Cancer Awareness Month. And I want to thank many of you who have participated in various colon cancer awareness activities this month. We had a town hall at San Francisco General. I think our fellow Edgar, Shreya Patel, and various other faculty are hosting the colon tube walkthrough, things like that. For awareness activities, many of the faculty also joined San Francisco Mayor at City Hall for colon cancer awareness talks as well. So in that spirit, we also have our visiting faculty today, Dr. Jennifer Christie, which I'm very honored to introduce to you. Dr. Christie does not need an introduction. I'll try. So she is currently head of GI and Hepatology Division at University of Colorado. She flew in yesterday, especially for us, and I was very honored when she accepted our invitation to visit. I'll admit that when we invited, we didn't plan that to happen in March, but it just perfectly happened at the perfect timing. So Dr. Christie is a past ASGE president. She has held various leadership positions at various institutions, including Mount Sinai, Emory, and currently at University of Colorado. She did her bachelor's at University of Michigan. She did her residency at in, I think, New York, and her fellowship there as well. She is a physician scientist with numerous 100 plus publications, book chapters, and she has done extensive work in disparities, colon cancer screening inequities, and gastrointestinal motility disorders. She is also the recipient of various awards, can't name all of them, but some including GI Mentor of the Year, Eminent Clinician, and Outstanding Faculty Award, and the list goes on. So without further ado, I would like to welcome Dr. Christie to speak to us on a very timely topic on disparities in colorectal cancer screening. This is a health equity issue. So Dr. Christie. Thank you so much.
Okay, good morning, everyone, and thank you, Api, for this just very generous introduction. I am truly honored to be here, seeing old friends, meeting new ones, and really talking about an important topic. And, I will say, Dr. Sherdo put me in a Waymo last night, and I was a little skeptical, because I had never seen or heard of this. But I asked her to take the license plate number and track me. and JT actually it was under him. So if I had gone missing, it would actually be JT's name on it. But it all worked out, and it was actually kind of cool. It was clean. So thank you. I'm excited to be here. And I also said last night we had dinner that San Francisco has a vibe. It's pretty cool. I get why a lot of people stay and stay and stay. So you guys are very fortunate to be here and to be working with such a great team. And thank you for inviting me. So with that, as Api said, we're going to talk about colon cancer and screening disparities. And, and my goal is to kind of walk you through what many of you already know, and many of you are doing work in this space, very important work, but also kind of talk through my journey through this and where I am now. So hopefully we can collaborate, or perhaps inspire someone to also join this journey, particularly now. So these are my disclosures. So the goal for us today is to, one, just kind of go over the current state of colorectal cancer incidence and mortality in the US, discuss some of the racial and ethnic disparities in screening, and also to understand what the causes of those disparities are through a health equity lens. And then lastly, to talk about some of the strategies that many of you are involved with here, and then also what we're doing on a national level with ASGE. So while we have, many of us in this room have done a lot of work to improve screening in the United States, it's still under the goal of 80% screening. And it's still, colorectal cancer still remains the second leading cause of cancer-related deaths. In fact, in 2025, about 155,000 people will be diagnosed with colorectal cancer, and we know that that does not need to happen. And unfortunately, 53,000 will die from colorectal cancer. And the scary thing is that about 11% of these people, and it's climbing, are diagnosed younger than the age of 50, hence some of the changes in the screening recommendations. In fact, young onset, young being under the age of 45, 40, which I'm a little mad at this point, but it's okay. I'm still middle-aged. I will be middle-aged forever, okay? But young onset has increased about 15% from 2002 to 2016. So again, fortunately, the incidence of colorectal cancer has been on the decline, and screening has been on the incline. But still, there are very distinct disparities in terms of incidence and death. And as you can see from the cancer facts and figure from 2025, that Blacks and American Indian Alaskan Natives have the highest incidence of colorectal cancer, as well as death from colorectal cancer. And again, we know that, we talk about race, and we talked about it a little bit last night, that it is a social construct, and that and in fact, these disparities do exist because of some of these social determinants of health that we'll talk about in a little bit. Went the wrong way. Now, when we look at the distribution of colorectal cancer in the United States, it's variable. As you see where I came from in the Southeast, it has the highest incidence of colorectal cancer. So that's more in the burgundy and the orange. And, largely that may be related to dietary variation, perhaps a more sedentary lifestyle, and obesity. We know that the obesity epidemic is throughout the country, but certainly in the Southeast. And then, but California and Colorado actually are doing okay. We can do better, but we're doing better compared to some of the other parts of the country. And again, because of some of the social thing, it's not like there's a gene that sits in the Southeast, right? But more because of the social determinants that we'll talk about. And in terms of, again, just looking at when you compare whites compared to Blacks, that we know that these gaps still exist. So we see that the incidence and mortality rates for overall are going down, but that difference between Blacks and whites is not. It seemed to kind of cross over in the early 90s for some reason, and then it just kind of has stayed the same. And the mortality rate has also pretty much stayed the same. And the ratio actually increased in terms of that difference between the 70s and 2000, but now with the improvement in terms of screening and trying to address some of these disparities, it's pretty much stayed the same. So the other thing I wanted to highlight is that, and this is based on the national data, that again, in terms of race and ethnicity, you see that non-Hispanic Blacks and American Indian Alaskan Natives have a higher incidence of distant colorectal cancer. So it's being picked up at a later stage, again, because of those screening disparities. And then certainly also and then when we look at age, we talked about age, the folks between 0 and 49 years of age actually have more distant disease compared to the other age groups, which I thought, again, very scary. and also more regional disease and less local disease. Again, because these, we're just really realizing that we need to screen these people earlier. And one would argue maybe we need to start thinking about screening even earlier in certain groups that we determine necessary. And this is for average risk. This is not people who have a known family history. These are average risk individuals. So these disparities, of course, exist along the continuum of cancer care. Maybe risk factors, again, probably because of the social determinants. Prevention, which we'll focus on today, screening, diagnosis, treatment, surveillance, and then overall survival. So, for example, we see that American Indian, Alaska Native women have a 4.5 higher incidence of colorectal cancer than white women. So again, that's in diagnosis. Blacks have more right side lesions. That's in diagnosis. Blacks have 35% or 38% less follow-up. Okay, so that's surveillance, and then that's going to impact survival. And then American Indian and Alaska Native women and men have a higher mortality rate compared to other ethnic and racial groups. So there was another important study that showed that 42% of disparities in colorectal cancer incidence was really due to screening. So that's really one of the reasons why I wanted to focus on that today. And 19% difference in mortality, again, is due to screening. So that's something that we have to continue to focus on. So why is that? We know that just as I alluded to in sort of the establishing the foundation of this talk, that it's related to health equity, some of those social determinants of health or lack of health equity. And I've been thinking lately, how do we talk about this now, right? Because we're in a very strange time, right? And my colleagues last night, we agree, we talk about it the same way we always talk about it, right? At least with each other. Now, when we talk about funding and other things like that, we have to discuss that, but it doesn't make it go away. So the health equity refers to establishing a system of justice where barriers that have historically disadvantaged certain groups, and I'm just going to read this out because I have to continue to even think about this myself. Historically disadvantaged groups, it keeps them from achieving good health care, education, housing, access to healthy food, and earning a good income to be able to do all those things, right? And so we have to systematically dismantle those. So in terms of how do we conceptualize these social determinants of health, I kind of took this from an article from Carruthers and Dubini, as well as Folame and her group, who did an analysis on how these social determinants of health may impact some of these disparities. So if you think about it in terms of upstream determinants, midstream, and then the downstream determinants, these are the factors that we think about, right? So structural and institutional racism, that's a huge component. Policy, which I'm going to focus on later in the talk. Bias, discrimination, poverty, social class. And then what does that then do, right? Then you don't have as good of an access to quality education, stable employment, housing, right? We see that in Denver, we see that in San Francisco, we see that in a lot of communities across the country. Food security, healthy food, being able to afford healthy food, immigration status, and then mistrust. And then what the hypothesis and what people are starting to look at is really how that may impact biological changes in the body. So alterations in the gut microbiome due to stress, due to food choices or food availability. And then the development of pro-carcinogenic byproducts, increased inflammation. We know that is a big driver in a lot of chronic diseases, including cancer throughout the body, and then leading to gene mutations, and then enhancing that adenoma to carcinoma sequence. And then, of course, leading to the increased incidence in colorectal cancer in these groups, advanced stage, and then increased mortality. got my arrows. Okay, so again, talking about the younger individuals. So overall, we see that in all ages, the incidence is declining in this panel on the left here. However, in individuals ages 20 to 49, it's going up, right? And we still don't understand why. Who are these people that we need to start to look at? People older than 50, it's fortunately going down because of screening, but in these individuals, it's going up. But there's also disparities in the racial and ethnic distribution of colorectal cancer in young groups. And this is based on SEER data a few years ago. And as you see here, that non-Hispanic Blacks and Latinos have a higher incidence of or lower overall survival from colorectal cancer compared to non-Hispanic whites. And then also cancer-specific survival, overall survival is low, and then cancer-specific survival is also lower in minoritized individuals. So what are the guidelines? So for a while now, the American Cancer Society recommends that the individuals really have choice in terms of what how they're screened. But in terms of the age of screening, the ACS has determined several years ago, I think it was like in 2016, based on some modeling data, that screening should start at age 45 through age 75. And then after about 76, maybe, depending on patient preferences and overall health, and then absolutely stop at 85. Now, I don't know about you guys, but some of my 83-year-olds come in for screening and they look pretty good. And they're like, let's go. And I'd go, I don't know. But I'll do it because they prepped. And then they're like, okay, when do I come back? And I'm like, and some of them feel some kind of way about it when I say, you don't need to do this, and clutching pearls and everything. I don't know what your experience is, but many of them who are healthy, they want to keep going. So but again, that's based on preferences, life expectancy, et cetera. So about 4 years ago, the USPSTF also came out with new recommendations based on when to start screening. And these are recommendations based on extensive systematic review of adults aged 40 years of age or older, evaluating the benefits and harms of screening. And this is really important because I'm sure many of you have seen that currently this is in front of the Supreme Court as to whether to allow the impact of these guidelines to influence coverage and insurance payments. So this is a big deal. And in 16 states, it's these guidelines that influence coverage. I mean, I think in more states than that, most 45-year-olds are being covered, but in 16 states, it is a policy, but that is currently under review. So based on that extensive systematic review, they determined that with high certainty that screening individuals age 50 to 75 has significant benefit. So the USPSTF has determined that to be a grade A recommendation. So it's recommended for all. For individuals age 45 to 49, they concluded with moderate certainty that it has moderate benefits in starting to screen that age group. So that's a grade B. And then as we talked about earlier, the adults age 76 to 85, they concluded that there's a small benefit with some small degree of certainty that they would benefit from screening. But certainly if someone who is 76 never has been screened, it makes sense to go ahead and screen them. And that could be with any of the available options. But also, again, based on overall health and patient preferences and comorbidities as well. So why does the USPSTF say to start screening at age 45? Well, again, they looked at some modeling data from the Cancer Intervention and Surveillance Modeling Network. And they looked at the years of life gained if you start screening individuals at age 45, also CRC cases and deaths averted and harms from colonoscopy or mostly colonoscopy in doing it in these individuals. And what they found in using all of the modalities here, that there was a significant number of years, life years gained if you start at age 45, with slightly larger number in performing colonoscopy every 10 years in these individuals. So hence it helped to inform those guidelines. So again, the ACS supports patient choice, either based on stool-based tests or visual tests. And as you all know, these are the various stool-based tests. There's some other emerging tests that we'll talk about. And then of course the visual tests with colonoscopy, CT colonography, as well as still FlexSig. But I don't really know many people who are still doing FlexSig, even in underserved communities. So again, it is important though, as we have these conversations, that our primary care physicians and other physicians and the patients, to the extent that we can explain it, understand the performance of these various tests and the availability of these various tests and weigh it against the benefits and the harms to the patient. So this data is based on a grade-based evidence review from Asma Shukat and her group, and this was published in the Red Journal several years ago. And then also this article by Lynn and colleagues was based on some data from Kaiser Permanente in looking at the performance of these tests. And as you can see, the sensitivity and specificity for FIT is pretty good, but that's based on one cohort study. The multi-targeted stool DNA tests, also sensitivity for colorectal cancer is pretty good, so 92%, but we'll talk about it for adenomas and advanced neoplasms. And then for CT colonoscopy, the performance for colorectal cancer is pretty good at 90 to 100%, but of course, these are larger lesions. For sessile serrated adenomas, it does not perform well. And then for colonoscopy, based on 2 large cohort studies, the performance is almost 100%, but with a good quality test. And then with polypectomy, it decreases colorectal cancer by about the hazard ratio of 0.53. And then mortality, same thing, decreases by about 68%. So I did want to just talk about this study that came out last year in the New England Journal, looking at the new generation of the multi-target stool DNA test. And this was published by Imperial and colleagues. And they wanted to compare it to FIT, and they did. And of course, when they looked at specificity after the patient had a colonoscopy, then they were able to assess the specificity. So they had over 20,000 patients that participated, and the sensitivity for the multi-targeted stool DNA test was almost 94% compared to a 67% for FIT. But of course, FIT is much cheaper to do, and also to perform outreach. And I know like Ma and others and Shreya and others in this group have done a lot of outreach studies to prove that it is effective in screening for colorectal cancer and decreasing incidence. But when looking at advanced precancerous lesions, it was about 43%. So as far as the sensitivity, and then for specificity, it actually improved. So the prior generation for specificity was a little bit lower for the multi-targeted stool DNA test, but improved at 93.4%. And for FIT, it's 96%. So other tests I just wanted to talk on briefly are these emerging blood-based tests. Now there's currently, or other tests in general, and I want to focus on the blood-based test. So for colon capsule endoscopy, not FDA approved yet, it has a sensitivity for 91% for advanced neoplasm, and specificity for 77 or at 77%. But it's really expensive from what I understand, right? And I think it's like double the cost of colonoscopy. So that's going to be a real issue. And then what we're calling these liquid biopsy methylated DNA. So this circulating DNA with these blood-based tests, there's 5 of them, but there's only one that's FDA approved, but none of them have entered into the guidelines yet, or the recommendations as yet. But the FDA says, okay, if someone really will not have a colon or cannot have a colonoscopy, doesn't want to do the stool DNA test, then it can be approved. But again, it is expensive and coverage is going to be an issue. And as far as the sensitivity, it's variable, right? Based on the person, based on the actual test that was studied, but it's 26 to 79% for colorectal cancer for sensitivity and specificity of about 70 to 85%. And then there's some of these stool-based tests, right? Looking at different microbiomes. So like the fusiform bacteria has been shown to be associated with colorectal cancer. And at this point, the sensitivity is about 78% and specificity it ranges between 62 and 78%. And then there's urine, right? There's now looking at urine-based tests. And for colorectal cancer, at least based on the studies, the sensitivity and specificity is not bad. But again, there's not a lot of data on polyps. So we're talking about prevention and not just diagnosis. So we need more longitudinal and comparative data to look at these emerging tests before they can be ready for prime time. So because I talked about the study on the new generation multi-targeted stool-based test, the same issue also looked at the cell-free DNA blood-based test. And this was done by Chung and colleagues, and using, I guess I'm not going to use any specific names, but using one of the liquid biopsy tests. They had about 7,800 individuals participate, and they compared it to colonoscopy, and they had and it showed a sensitivity about 83% for colorectal cancer. However, for advanced precancerous lesions, it was only about 13%. So again, it's okay, pretty decent for diagnosis, but it's not a prevention test, right? So that's something we have to, at least not now, we have to keep in mind. And then the specificity for no colorectal cancer or advanced lesions was almost 90%. So we can't talk about these potential screening tests and the benefits without the harms. So for the stool-based test, again, when you're talking to your patient and they say, I don't really know about this. I don't want to handle my stool. Like, that's still kind of taboo with a lot of folks, but a lot of people do it and are okay with it. But also, as we discussed, it has a lower sensitivity and specificity for advanced adenomas. And that's what I always tell patients. The benefit of doing this is really finding these lesions early and removing them before they can transition. And then the anxiety of the stool-based test, if it's positive, right? Why is it positive? And then having to do a follow-up colonoscopy anyway. And then, of course, colonoscopy, more invasive. One would argue more potential harms. So in terms of bleeding, it's still not high, but something to consider. 8 or 10,000 in the average risk individual. And then perforation rate is about 4 per 10,000. But then patients said, I don't want to do this bowel prep. It's disgusting. It's hard. And then a lot of folks just can't get off work to do that, particularly a lot of the patients that we serve in our underserved communities. And then transportation. I've learned this, and I'll talk a little bit about our colorectal cancer screening project with ASG, but even in rural communities, they don't have anyone to pick them up. There is no Uber. There is no Waymo, right? That's what it's called, right? Waymo. So that is a real issue. and that we may not consider, particularly being in an urban environment, that in rural communities, that is a barrier for many folks. And then for CT colonography, the radiation, and then what do we do with these incidental findings? And then that's the same thing that I always think about with these blood-based tests. Like, what do we do when it comes up positive and their colonoscopy is negative? So in terms of screening test utilization, I thought this was important to highlight. Now, while it's interesting to see that, at least based on the review article by Fola May and colleagues, that and national data, that the actual screening for colorectal cancer is very similar between whites and blacks, but less so for Latino patients. And certainly for American Indian and Alaska Native, and also Asian American patients. But this data is, but it doesn't drill into, well, what patients are having colonoscopy, which ones are having FIT, et cetera, right? But the screening rates are at least similar between blacks and whites. But if you drill it down based on social economics, you see that education status, so higher education, we're not, and this is not, we're not surprised here, that more patients who have a college degree tend to be screened. Patients who have insurance, there's a huge gap in terms of who gets screened. Patients who have a higher income have no surprise, are more likely to get screened. So they have insurance more than likely, or some access. These are some of these differences that we want to highlight here, and why these disparities in incidence and death occur. So early in my career, I became, and this is when I was at Mount Sinai, a junior faculty. I would love to always say I'm a junior faculty because you get a little bit of a pass there, but I can't anymore. But I became interested with some great mentors in these barriers to screening, and did a lot of work on what are the barriers, and then we'll talk about patient navigation. And what I learned is that it's complex, right? And there are patient barriers, there's structural or system barriers, and then there's provider barriers, right? But nonetheless, they all have to be addressed on some level. So in terms of the patient barriers, and this is all based on, a lot of work that has been done amongst our colleagues and work here as well, is that there's clearly some, which we just talked about, social economic barriers, right? Like income, lack of education about screening, right? Health insurance, but they all drive each other. There's medical barriers for the patient, other comorbidities, higher priorities as far as their health conditions, and then their understanding of the importance of screening as well. And then what is also very significant is some of these psychosocial barriers that occur, understandably so. So mistrust, fear, and also just different cultural beliefs about screening and different types of tests and about cancer. So as part of that work, and early in my career, we looked at some of these factors. And then because I was at Mount Sinai, which is on the Upper East Side in New York City, there was a huge Latino community. So we looked at some of these barriers to screening, and we found that in some Latino populations, that cancer pros were, just less than the cons, right? So people are like, well, if I get cancer, I don't know, and the screening test, it's just, I don't really think it's going to impact me, right? Or help me. If I get it, so be it, right? So that was a huge factor. And then also the insurance status, that was a huge factor that we also illuminated. And then language barriers, that's a huge part in just terms of communication, understanding, but also that feeds into trust. And then what has been shown in the Black community is that there's fear, a lot of fear around cancer, and then also fatalism, right? If I get it, I'm supposed to get, that's what God has for me, and so be it, right? And so how do we try to not undo that, but how do we try to manage that and let people know that there are things that you can do to decrease your risk and certainly your death from colon cancer? And then in Alaskan Native and American Indian populations, there's historical trauma as a major factor around healthcare, right? And certainly screening. I don't have symptoms. Why do I need to do that test? And then just some basic communication around cancer. I learned from Fola May that, and correct me if I'm wrong, but there's no word for cancer necessarily in some American Indian communities. So it's hard to even communicate that. And then that mistrust is something that is very common, unfortunately, amongst some of these minoritized groups. So that's something that we have to continue to challenge. So looking at physician barriers, this was a study that also was done by Fola May and colleagues. And basically it was lack of recommendation for screening that was a huge driver. And why does that occur? Maybe just lack of continuity of care in these groups, physician knowledge about it, when to start, who to screen, who not to screen, how to screen. Visit time. There's time constraints even having these conversations, and then bias. And then this lack of recommendation has been associated with lower education, income, and unemployment. And when they looked at specific groups, so that it showed that compared to whites, African Americans tended to have a lower recommendation from screening from their primary care physicians. But it's interesting for Asian Americans or Asian English speaking individuals, it was associated with this is non-adherence to screening because of the lack of recommendation, that Asian Americans who spoke English actually had less adherence, which I don't understand compared to those who did not speak English. And then certainly higher insurance copay and high insurance copay versus no pay was associated with lack of adherence. And that's what this plot represents. So why is this and what do we do? So again, health equity, that's how we started, but that's the center of this conversation, and how do we achieve that decrease in those disparities. So this relates to doing more research. That may be a little bit challenging right now, but it's not something that we can afford to not pursue. Try to increase access to care, building trust, as we discussed, patient education, and then health advocacy. That is a huge piece at the federal and the local level. Is very important to reduce some of these barriers to colorectal cancer screening, which I'll talk about with our ASG project. So some of the recent policy interventions include elimination of the colorectal cancer screening cost sharing policy through the ACA. So that was back in 2010. So and I think that has made a significant impact on increased screening in these groups. In 2022, CMS said no out-of-pocket costs for follow-up colonoscopy in patients with a positive stool-based test. And then the lowering the age of screening based on the USPSTF recommendations. But that's something we have to keep an eye on and make sure that we advocate. And it sounds like a lot of you did that this past month in recognition of Colorectal Cancer Awareness Month. And then again, elimination of that screening to diagnostic cost sharing piece. That was really important for patients. The so-called surprise billing, right? That's what that is. And then again, I mentioned the guidelines being in front of the Supreme Court and impacting coverage for colorectal cancer screening. So we have to continue to advocate against changing that. So in terms of this health equity, now this is a framework that was kind of put together by several people, but mainly John Carruthers, Dr. Dabini and colleagues, Samir Gupta, in terms of how to think about health equity and the framework, and then what interventions to reduce colorectal cancer screening disparities. And so it's very complicated, but what I've already talked about is understanding and trying to deal with some of these social determinants of health, which is a very high level challenge that is in front of us. But other things that we can do at a local level is things like patient navigation. I've highlighted them here. Population-based approaches, which many of you have done here. Kaiser Permanente has done successfully in their mailed fit outreach. Community engagement and outreach. So really connecting with local and state stakeholders to bring them into the conversation and get their buy-in. Mass media and education to communities. And then removing some of these structural barriers and the costs that I talked about, some of these policy interventions, but also trying to develop quality metrics that allow us to assess follow-up. And I know there's a HEDIS measure currently and be under discussion about how to measure follow-up colonoscopy after a positive stool-based test. But these metrics really drive people, physicians and other healthcare organizations to push it in the right direction, right? Because everybody wants to have demonstrate that they are executing on top quality and they're meeting these metrics because they have monetary implications in terms of your reimbursement, right? So establishing these quality metrics are very important and disseminating them and having people drive towards them. So in terms of patient navigation, again, early in my career, I looked at that with some great colleagues about, does it work, right? And so what is it? So this is a patient-centered intervention that uses trained personnel. And these could be people, they could be medical assistants, they could be, other community healthcare workers, they could be patients who are then, who have an experience with either screening or colon cancer. And this has been utilized in many other types of cancer, breast cancer, prostate cancer, cervical cancer, and all shown to be helpful. We looked at a small group of patients who were being recommended for screening for colorectal cancer. And these people are trained to help coordinate these referrals, support and act as a patient advocate, right? Oftentimes, and if you have someone who doesn't speak English, having someone with a similar language, they can communicate in a reliable way to these patients, facilitate these appointments, remind them of their appointments, and also coordinating follow-up from said test. And so we looked at, we randomized patients to be navigated or not receive navigation. And we in total had about 40 patients. And we, as you can see here, the navigated patient had a higher completion rate, and this was just for screening compared to patients who were not navigated. And this was for colonoscopy specifically, and that was statistically significant. So in terms of the cost effect, and there have been many other studies looking at this, and looking and using stool-based tests as well. So people say, well, do you need that? Can we afford this? So this is a simulation model that was constructed using a colorectal cancer screening navigation program for Hispanic men. And this was done in Wisconsin. And what they were looking at is basically, they looked at a number of things, but this particular Markov model, which I had to look at for a while to understand it, but it really looked at the cost of the screening program for navigated patients versus patients who have usual care or status quo. So the status quo is in pink, the navigated patients are in blue. And basically it represents that at assuming that some 80% effectiveness, which is patients who were reached out to by the navigator and actually completed screening, that's the effectiveness. As long as it was 80%, there was a cost savings in those patients, and it costs about $500 per patient who was navigated. And that continued up until, if you double that to 2.5 times that, then in terms of the cost, then you lose the cost effectiveness. And that is what this model is demonstrating here. So, but as long as you get at least 80% of these people in the effectiveness, then the cost is acceptable and reliable. And then this was another similar model, but this was done looking at low-income patients in New Hampshire, and these were mostly African-American patients. And this is a two-way sensitivity analysis using different willingness to pay values, which I learned is an economic metric that they use in a lot of health economics. And they looked at patients either in the endoscopy center or in a public health scenario. And again, basically what it shows, and then this willingness to pay is, they looked at it for $1,500 versus $1,000. But either way, patients in the blue who were navigated, it was cheaper to have them navigated, whether you did it in the endoscopy center or in the public health scenario, like a health system, than it was for usual care. And that's the pink. And it was the same for the various willingness to pay parameters. So then what do we do, right? So as Api mentioned, I was initially at Mount Sinai doing some of this work, decided to move to Atlanta to Emory. I would really develop my career in motility and really was seeing patients, still screening, still giving talks about this, but not necessarily directly doing some of this outreach and research work. But I decided as I was kind of progressing up through the American Society for Gastroendoscopy that I wanted to use my platform to really make a difference in this space. So, there's a lot of work being done for screening, whether it be for FIT, for Cologuard, for multi-targeted stool DNA versus colonoscopy. The big issue, though, is patients who have a positive of any of those tests and they need follow-up. So as I mentioned, we know that the screening rates have increased. Mortality and incidence have decreased, but the rate for follow-up colonoscopy for uninsured and underinsured patients who have a positive stool-based test is still very low. So this 50 to 70%, and some could argue that's even lower in these groups. So again, wanted to use my platform to really impact that and make sure these patients get follow-up. And the reason why follow-up is important is that we can see in this panel here that, first of all, the rates, as I mentioned. So if patients, the y-axis is patient who actually follow up, x-axis is time to follow up. So once you get to about 100 days, 90 days of post positive stool-based test, the follow-up doesn't really change. Even you get out to a year, it stays about the same. So these patients have a positive stool-based test. And so that's about 45% of patients, but never get follow-up. And this, again, this is average, and this is based on work from Mole and colleagues. This is average. For underinsured or uninsured patients, it's more likely lower. And this becomes important because we can see that it is clearly associated with colorectal cancer mortality. So the green line is people who comply, right? And actually have follow-up. You see the mortality is lower for them. And this, call it orange line, is people who don't. And so their mortality from colorectal cancer is much higher. So we decided, again, with ASGE, collaborating with Exact Sciences, who provided this grant, that we would develop a financially sustainable model to ensure that individuals who have a positive stool-based test get a timely follow-up colonoscopy. We're using patient navigation to be able to get patients to complete that process in a timely fashion. And our goal is to develop a model. We've been working with legislators, and I'll show you some of that in a little bit, to develop a program in both the state of Georgia and Maryland to have education to patients and primary care providers, navigation, and an outreach component to make sure these patients get follow-up. And then we're educating lawmakers about why this is important, because we want to put it in their funding process, right? And there's been a lot of folks who have their personal stories that really help to impact their support for us to do this. So it's really exciting to do this. So again, I've been fortunate to use this platform. But again, the goal is to look at a suburban/urban community, which is in Maryland, and a rural community in Georgia. Partner with the community and industry stakeholders to identify patients who need screening, and then if they have a positive test, we make sure they get colonoscopy. We're working with charitable organizations and other primary care practices to identify these patients. We're using patient navigation to ensure the follow-up. And also if they have a cancer or advanced polyp that cannot be removed by endoscopy, that they are able to get the care that they need. So we're partnering with people who have a charitable care process where we can get these people who are uninsured, get them some access to coverage so they can get the care that they need, and then the follow-up that they need. So this is the council that I'm working with. As you can see, these are people from all over the country, including your very own Dr. Luke John Day, who is on this council, that is advising and working together to ensure that we execute on this appropriately. But again, this collaboration is really the foundation for our success, right? So in addition to the people I just showed you, we're working with healthcare systems, physicians, and allied healthcare professionals. We have champions at these sites that are making sure that this process moves, the patient navigators, the legislators, and we also have some advocacy groups that we're working with. So there's 3 phases. We're now in phase 2 where we're implementing the project. Phase 3 will be to analyze how many people we got screened. The target is 300 screenings at each site, so a total of 600. And then developing a playbook that we can then use to policymakers to ensure some funding for this initially at a state level, and then maybe in a few years at a federal level. So some of our accomplishments, we had an initial national summit at the ASGE headquarters in August of 23. And we just got our white paper out that summarizes some of the things we talked about, where we included a lot of the, of course, the advisory council, but other people across the country who are working on colorectal cancer screening and outcomes. These are just some pictures of like Colleen Smith talking at the various regional meetings. We were featured in the White House Moonshot fact sheet in May of 24. We have developed educational materials for our patients and physicians. We've developed a workflow, data collection sheets, and we've presented that at NCCRT, DDW, and the Southeast Consortium. And then we're doing a lot of press releases to increase awareness. And really our goal, and this is from the article that I mentioned that we just recently published, actually in this month of GIE, gastrointestinal endoscopy, but basically how we're trying to address some of these factors, both starting at the system level and then working into the individual level that we talked about. So some of the advocacy work that we've done in Georgia, again, we passed resolutions in Georgia, screening resolutions in 23 and 24. We hosted a summit with the legislators and stakeholders. I got to meet a lot of them. They shared their stories. And we went to the Georgia Senate and the House. And also we met with leaders in August of 24 to advocate to put it into their state budget to cover the stool-based test and follow-up colonoscopy. So that's yet to be seen. We're hoping that that will happen in 26. I was in Maryland on Friday, and these are just some of the pictures from my visit to Maryland with some of the legislators and senators and delegates. But they presented us with Senate and House citations and resolutions. And again, this is really to make sure that they understand the importance at the state level so that we can drive funding. And in Maryland, they're actually, so monies have been set aside under their cigarette restitution fund, right? Which is a sort of a tax. And so you use that money. And a large portion of that fund has already been dedicated to this. Now, whether that changes, we'll see. But at this point, it has been dedicated to continue to execute this project even after this initial pilot is over. And so currently our current progress. So in Georgia, they're doing really well. This is a picture of the health center that we're working with. This is in rural Georgia. I drove out there about a year ago. I was like, this is rural America. But it was really interesting because it wasn't Black, it wasn't white, it wasn't Latino. It was just rural America, right? And a lot of low-income people who don't have access. So it was, it was actually very moving to me to really experience that. But we've done, there's been 47 normal, but the abnormal rate is high. It's 16 stool positive tests. Most of those patients have been scheduled, and we actually have a colorectal surgeon doing this because there's no gastroenterologist for like an hour and a half. But I spoke to him, and he's his adenoma detection rate. He's going to be tracking that, right? And 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 he actually found 11 polyps in one patient. That's how I wanted to let you guys know that. So not to say that I don't expect that, but but this is what we do all the time. So and then in Maryland, we're working with the Medi-Cal family practice, and they started a little bit slower. We have 13 stool-based tests that have been ordered, and I think there's only like 2 positives, so they have to be scheduled. So anyway, so that is part of my story, and the impact on colorectal screening disparities that we are trying to make. And so we really have to create equitable systems to make sure patients get cared for. These interventions are multi-level, and they're not easy, but we have to do it. And I want you to use your voice and your platform as it continues to evolve, to advocate for whatever it is you are passionate about, and the element of healthcare that you want to continue to improve outcomes in. And so I want to thank, this is from the summit, this picture of all the people who are involved in this group, and ASU and Exact Sciences for supporting the project. And also we have a lot of community organizations and also other industry partners who are supporting PREPs and the colonoscopy. So again, that collaboration is really the key to this success. So thank you. And I know I went over, happy to take questions.